presentation is to review HIV testing, labs, and diagnostic procedures for Concepts 2 students at CCBC. The first step when we think about testing for HIV is looking at a health history and deciding who should be tested. So those patients who are obviously at higher risk are patients who have unprotected sex, or who are a IV drug user, or men with men sexual contact. This YouTube video that I have listed in the presentation, I will also place within one of our folders in this Blackboard course, so you can see the idea of what happens with a one-time unprotected encounter and how that number increases through your lifespan. Testing. So first thing with testing is you should understand the state laws for testing and who should be tested and when they should be tested. And state laws goes along with the idea of informed consent. So in the state of Maryland, nurses cannot get informed consent for HIV testing unless they have been specifically trained by the state of Maryland. And you will see in some emergency rooms now that there is an HIV nurse who asks patients and family members if they'd like free, private, confidential HIV testing. And that nurse does get the informed consent from that patient. The other idea about testing is that goes along with laws is the idea of results. So we'll talk about negative first. A negative result, the patient should still have counseling on at-risk behaviors and be encouraged to decrease their at-risk behaviors. And if they've had a encounter with someone who is HIV positive, to continue to have HIV tests every 6 months. And then confidentiality. Confidentiality does go along with this idea of state laws that you can only tell the patient about their status. You may not tell a family member or a friend or their significant other, even if you as a nurse do not agree morally and ethically with their decisions. We have to remember that we are taking care of the patient, and we have entered into that patient-nurse relationship, and part of that patient-nurse relationship is confidentiality and respect. We have to respect our patients' decisions to tell their partners or to not tell their partners. So diagnostic testing. One of the first things that we do is an EIA, or they often call it an ELISA. And that tests for the presence of the HIV virus. We then also have a Western blot. The Western blot confirms the EIA or the ELISA. It detects antibodies to HIV. So if you have a patient that has a positive ELISA, they will then have to have a Western blot to confirm the EIA. One word of caution is that you can have a patient that has a Western blot to look at Lyme disease as well, to confirm a diagnosis of Lyme disease. So just because they have a Western blot ordered does not automatically mean that it is for HIV. Consent has to be received from the patient to draw an EIA. Consent also has to be from the patient to draw a Western blot. You also have to have consent for a patient to draw viral loads and CD4 and CD8 counts as well. So ways to perform the diagnostic testing. We have an OraSure, which kind of looks like a pregnancy test that you roll in the inside of your mouth, and that picks up DNA that can identify if they're HIV positive. Or you can have an Ora Rapid Quick HIV Antibody Test, which is like a capillary stick or a blood sugar stick, and those results come back instantly. Instantly is like a 15 to 30 minute window, but patients know very quickly if they have the HIV virus, if they have HIV virus within their system. The Western blot testing, remember, is the one that we use to confirm the presence of HIV, and that takes 10 to 14 business days. So at that point, we need to have a conversation with our patient about what to do within that 10 to 14 days. So they don't know if they're HIV positive yet. So we want to talk to them about refraining from unprotected sex, refraining from using IV drug use and sharing needles, and maybe ask them to really think about telling their partners that they are with currently or have been with in the past before they have the results of the Western blot, because they're not 100% sure that they have HIV at this point. So diagnostic testing, viral loads. One thing I will say about viral loads for testing purposes is that I want you to understand that a viral load is elevated or decreased. Viral loads, the sensitivities for viral loads change over time. I think since I've been a nurse in the 20 years that I've been around nursing and in nursing school and been a nurse, viral loads have changed about 3 times. So the technology gets more sensitive and they can count them better. Just understand that a high viral load means you have lots of virus in your blood, and a low viral load means you have low virus in your blood. High viral loads often correlate with low CD4 counts. It's like a teeter-totter. When one goes up, the other one goes down. So then we have a CD4-CD8 ratio, and these are markers found on lymphocytes. HIV kills CD4 cells, which results in a significant impaired immune system. CD4 cells decrease and CD8 cells increase in the response to infection of a normal immune system. So, if you think about it as a ratio, the normal CD8 number is 1,000. If I have a patient that has a CD4 count of 500, my ratio is 500 to 1,000, or 1/2. A normal person with a functioning immune system, their CD4 to CD8 ratio is 1. So if my CD4 count is 1,000, my CD8 count should be 1,000 or greater. Patients that have HIV and are showing a progression of the disease, their CD4-CD8 ratio will decrease to less than 1. A CBC, or looking at we're monitoring for anemias, presence of leukemia, which would be an increase in your white count, and identifying any active infections. So platelet counts, we're looking for thrombocytopenia, which are low platelet counts, and that's often due to patients who are actively taking the heart medications, the highly active antiretroviral therapy. Chemistries such as BUNs, creatinines, liver enzymes are needed to monitor liver and renal functions, because medications can alter these functions. Also, sometimes patients may need the dosage of medications reduced due to these functions. And finally, an MRI or CT scan. They are often performed for patients where we suspect they have opportunistic infections, such as TB or PCP pneumonia, or what we call neuro-HIV. Especially TB, we do CT scans on patients that we think have TB to identify how large the cavities are. And then patients that potentially have neuro-HIV, where the HIV virus has gotten into their cerebral spinal fluid and has gone into their brain, and we would do an MRI.